step forward. Jason in the end. So I say to step forward.
Oh, okay. Great. Good morning, everybody. Or afternoon, rather. Because we just crossed the 12 noon mark. I'll be presenting more like work in progress, what I've been doing well, over a couple of months now, trying to reassess global antenatal care coverage, trying to make sure that every antenatal care coverage counts. It's methodological, so you will pardon me if I shoot some slides, but I'll try to avoid them. I'll just give you what that means and then we'll get it right. If you have a few questions, we can say that and I will tell you exactly what's going on there. I'll give you some overview of issues that we need to be aware of, then the objectives of this presentation, methods that I proposed for reassessing ANC coverage globally, and then we'll talk about findings and conclusion. Well, there's a global concern, especially within developing countries, to improve maternal and child health outcomes. Developing countries have the largest share of ill health, including child and maternal ill health. And the UN Millennium Development Goals actually put in place many measures or objectives for us to achieve. Some were not met, so many countries were not able to meet the MDG goals, especially those pertaining to maternal and child health. And these countries are predominantly within developing countries, including Africa. And then the current SDGs came along, and SDG 3 is about health and well-being. And within that, there are many sub-goals, which I'm particularly interested in, 3.1 and 3.2, that is maternal mortality, trying to make sure that at least we reduce maternal mortality by 70 per 100,000 live births by end of 2030. And newborn / child mortality, which is I think about 15 per 1,000 live births and 25 per 1,000 live births by the end of 2030. That's what the SDGs are planning to achieve, hopefully. And we know within that context that antenatal period, that is a period between conception and birth, is actually an interesting period, an important period for us to target interventions that will reach women, as well as the unborn child. So you're basically targeting two people at once if you have good interventions. And it's been one of the indicators that was put into the previous UN MDGs. And again, kind of not explicitly within the SDGs, but we also know that access to ANC or use of ANC service can be seen as an indicator of access to health services, especially for pregnant women. So it's equally another good indicator in terms of access to health services. Let's give you a quick overview of some statistics. I hope it's kind of clear. My worry is within the African region. So if you look at this carefully, you will see, let's look at this. This is easy to understand, pretty much the same picture. You will see that Africa is the one that drives the largest. The global average is somewhere here, which is driven, sorry, the global average is somewhere here, which is driven largely by the distribution of Africa in terms of maternal mortality. And average for Africa is the largest compared to every other region in the world. So it means that maternal mortality is a big issue. This is Sierra Leone, which is really an outlier. You have countries like Nigeria, somewhere here. Well, see the distribution that's it.
Where's South Africa?
Well, South Africa is somewhere yeah. Botswana, Cape Verde, Cabo Verde is actually, these are countries that are doing relatively well compared to Nigeria, Chad, Central African Republic, and Sierra Leone. I've come to this issue of Sierra Leone in a while. We'll come back to it. You'll see something very interesting there. Then again, if you look at neonatal mortality rate, pretty much similar distribution, but this time around you find that Eastern Mediterranean region is also contributing substantially to high neonatal deaths globally. Similar to Africa, but Africa is more in terms of Africa starts here compared to Eastern Mediterranean region, and that's pretty much close to zero. So again, this global average is driven largely by these three regions: Southeast Asia, of course, Mediterranean region, and Africa. Again, highest still in Africa, Angola this time, driving neonatal deaths in sub-Saharan Africa. So now, keeping that in mind and knowing that access to ANC is very important for mothers, pregnant women, it's also a way to reduce as much as possible maternal mortality. If you catch things early, you'll be able to avoid such deaths. WHO, for some reason, dating back history, has come up with a magic number of 4. It's a magic number. For some reasons, reading through history, how the number came about is really not totally scientific. I must tell you, it's not totally scientific. So it's a magic number of 4 ANC visits, especially in the case of uncomplicated pregnancies. A pregnant woman should have at least 4 ANC visits before birth. Now there are issues around the timing of the first ANC visit that should be in the first trimester or the first 3 months or first 20 weeks, etc. Rather than having 4 ANC visits, 4 days to delivery. So now you see you can't have a country with a very high ANC 4+ coverage. Perhaps the 4 visits were just a month to delivery. And then you could have a country where you have 3 ANC, very high coverage with at least 3 ANC visits, and they're well spaced. First trimester, third trimester, and then possibly the last, second trimester, and then the third trimester, for instance. So we know that, yes, having at least the so-called 4 ANC visits increases the likelihood of receiving effective maternal health intervention, especially in the case of uncomplicated pregnancies. Because when you have complicated pregnancies, the number is not, you can't really determine. There's been lots of studies in the economics literature dealing with the impact of ANC on child health outcomes, especially on child birth weight. And there is a positive relationship in the sense that women that tend to have more ANC visits will have children that are not underweight. Although, again, like I said, there are issues around the adequacy or content of the visits, which have not been captured in such studies. The fact that you had 4 visits or 5 or 10 may not convey much information, especially if the visits were, of course, to train personnel, but maybe there was little or no scan or no kind of check blood pressure and the basic kind of tests that need to be carried out. And of course, the issue of adequacy will come to that. Sometimes that proportion is augmented with having at least 1 ANC visit. So you have countries reporting that measure and then this other measure, having at least 1 ANC visit before birth of the child. So I'm taking those 2 indicators as my point of departure. Here we know there is the 4+ ANC visits and the 1+ ANC visit. But these visits or those indicators are, one, not sensitive to policies that increase the proportion of women that have attained between 2 and 3 NCVCs, for instance. Okay? Now, you could have a country with a certain percentage of women between 15 and 49 who are pregnant within the time period who had at least 4 ANC visits. But if there is any policy in place to increase the number of women with 2 visits to become 3, or 1 visit to become 3, it's not being captured by the 4+, but such countries are making some kind of progress towards the goal. If the goal is 4+, or it's 5+, or whatever we decide soon. And that is not, that's one of the issues I'm talking about, that it's not captured, it doesn't really capture the progressive realization that is enshrined in the SDGs. That is, you want to achieve something progressively. The 4+ is like a cut. If you don't achieve it, you've not achieved it. You're waiting, so you don't even know whether you're getting closer to achieving it or not. The moment you achieve it, you know you've achieved it. So you want to also see within, using policy to know whether you're moving in the right direction or not, rather than waiting to see 4+. And if it's not yet 4+, you're not doing well, for instance. So you will see in a while that you could have the same 2 countries with the same proportion of women attaining 4+ NCVCs, but they're not the same in terms of progress being made by one compared to the other. That's not being captured. And of course, does not account for quality of NCVCs. And again, the last one which I talked about, timing. It doesn't really say whether the 4 visits were 4 days to delivery, or maybe the woman was admitted for 4 nights or 4 whatever, and then that's counted as 4 visits, etc. Before delivery. The issue of quality is very important, or adequacy or content of visits. So the purpose of this, my study, is the first phase is to propose a simple index for now of ANC visits using the number of contacts, because that's what we have in current surveys. I want to use what we have in current surveys first before we move to the next phase, which is about changing the surveys. So let's use what we have now to see what we can assess in terms of progress towards achieving maternal health indicators, good maternal health indicators. Then we'll now push the boundaries to see what we need to incorporate into surveys in the future. So the simple index will basically take into account, it's like a full distribution over the entire use of ANC services. Of course, I was limited in terms of timing, still not captured in the surveys. So it doesn't really tell us when the first, the second, the third, the fourth were all achieved. But you may have whether the first ANC is within the first trimester or not, and thereafter, nothing else. So I also propose an extension to the initial index. That is, it's a generalized index. The reason why it's generalized is that it can accommodate anything you want it to accommodate. So whatever you throw at it, it's easy to accommodate. So it accommodates that to be able to take into account any measure of quality that you want to build into the model. So it's simple, like I said, it's very simple. The proposed index follows this architecture, but for brevity, I will skip this and give you an alternative computational procedure that is simple. Yeah, for brevity. Okay, let's not go into that. Yeah. This is simpler to understand than this. This needs a little bit of some. Yeah. So now let's look at the alternative computational method. Gives you the same thing, but I prefer the other one because it allows me to do more things than this. So if we define something called V as the total number of ANC visits for each woman, age, blah, 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 with a live birth. So for instance, if there is a Ntombi and Ntombi had 3 visits before delivery, then her V would be equal to 3. And if there is Ntokozo with 5 visits before delivery, Ntokozo will have 5 visits. And if there is Jane with 2 visits, she would have 2, her V will be equal to 2. Okay? Very simple. Now, we want to censor that distribution. We're censoring in the sense that we want to define a minimum. If WHO gives us a minimum, let's stick to the WHO minimum for now. We can shift the minimum. The model will allow you to accommodate if you want to shift it to 5 to 6 to 7, whatever it is. So we can shift the minimum to, or keep the minimum at 4 or 5 or whatever. That's the minimum. So what we're saying is the censor distribution would be, for instance, 3. If 3 is less than 4, of course it will return 3. But if you had 5 visits, then it will return M, which is the minimum, 4. So your V asterisk would not be greater than 4 in this case, if we set 4 as a minimum. Okay? So you could have 0, 1, 2, 3, 4 as maximum. If you have 5, we'll give you 4. If you have 10, we'll give you 4. Because it's assumed in this model that anything above 4 is good, but it doesn't change anything anymore. It doesn't. Even if you have 100, it's not going to change, provided we're dealing with uncomplicated pregnancies. So we'll keep our M as minimum. Then we will basically compute the coverage index just by using this, which is very simple. So what we're doing is we're adding up all these for all pregnant women in that country in that year. So remember, it will be 0, 1, 2, 3, 4 in this case. Then you basically divide by the number, the minimum, which you set here. If it's 5, it's going to be 5. If it's 6, it's going to be 6. And then dividing it by that. So it's basically an average, some kind of weighted average that is being weighted by the inverse of this. So this is an average that is weighted by the inverse of this. Pretty, very simple to compute. There is no kind of hidden stuff there. And then the gap, the coverage gap is basically the complement of that in the sense that it's 1 minus that. So you take that, 1 minus it. So the coverage indicator and the coverage gap will add up to be 1. Okay. So I think that this is simple compared to trying to explain this to you. I will struggle to explain this to you. But this is easy to explain. But in the paper you would see both well explained if you're interested. So the interpretation, the value of each index, whether it's I or G, would range between 0 and 1. When the index of coverage, coverage index rather, is tending to 0, that is becoming 0, it's the same as the gap becoming 1, which means, remember, it's complementing each other. So it means that the level of ANC coverage is extremely low, and of course the gap is high. Coverage gap is high. And when the index tends to 1, that means it's full coverage, basically. It's the same thing as having no gap. It means that this is tending to 0. There's extremely high ANC coverage or extremely low ANC coverage gap. Okay.
So it's not extremely low, it's completely absent.
Well, tending to. Well, maybe because I'm using mathematical term here. In mathematics, this means it's not yet 0, but it's tending to. Yeah, it's getting to 0. Yeah, it's tending to, not equal to. Yeah, but if it's equal to 0, it's of course completely. So for progressive realization of ANC coverage, countries should aim to maximize I, or the inverse, minimize the gap. So if you minimize the gap, you're maximizing the coverage. So whichever way, minimize the gap and maximize the coverage. Okay, now let's take a look at a very simple illustration here of how for you to understand where I came from to develop the index. Now let's imagine we can have that particular stuff there. What this means is women that have at least, the proportion of women that have at least 4 ANC visits will be here. And in this case, it is equal to whatever it could be, let's say 0.35. For instance, say it's 0.35. So it means that about 35% of women in this country have attained at least 4 ANC visits. That's what this tells us. Okay, there's a line here, but I just basically hid it for some reason. So you have about 35% of pregnant women in this country attaining at least 4 ANC visits. Now, because this is cumulative, because I'm accumulating down this way, whatever I have here cannot be less than this. It cannot be less than this because women that will have at least 3 ANC visits would include women that have had 4 plus or more. So it cannot be less. So this will always be a step or to be a flat line. Wherever I start, it's either going to be a flat line or it's going to be a step upward. It can never go the other way. Then it now shows us that about 59 or 58% of women in that country have achieved at least 3 ANC visits. Then you go again, maybe about 70% have attained at least 2 ANC visits. Then you have about 90% attaining at least 1 ANC visit. Then the remaining 10% not shown, no visit. Okay, so you can easily plot this for every country. If you have data, you would see how coverage gap or coverage whatever gap or the coverage itself is. So to estimate that coverage gap or coverage indicator I showed you is basically this, the analog. The analog is basically an area. So we're going to compute this area. So what is this area as a fraction of the entire area? Will give us the measure of coverage. And then by reverse or complement, the gap will now be this area, the share of the entire area. So maximizing coverage is all about making sure that this is basically clear. As soon as that is cleared, then you have a very high coverage index or indicator and a very low or 0. It becomes if it's eliminated and this is 0. So that's exactly the intuition behind the piece you see here, which you will not get from here, but you'll be able to get from here. This, which I didn't explain, will give you an idea of how it came from there. But of course, this is basically an alternative computation method. Simple to arrive at that. Okay, so let's look at something quickly. This is a hypothetical country where 49% of women aged 15 to 49 who had a live birth in a given time period, a year or 2 years or 3 years, depending on what the DHS gives you, attained at least 4 ANC visits. That's a hypothetical country. 49% have attained 4 ANC visits, and that's all we know. But it's possible that any of these scenarios is playing out in that country, but we don't know. But there's a scenario that is better than the other, and there's a scenario that is worse. If you remember what I gave you earlier, in terms of coverage, I basically switched the shading this time around. I shaded this part, it's basically the same thing. So here we have, it's possible that 49% of women have attained at least 4 ANC visits, but the rest have achieved at least 3. So coverage with at least 3 ANC visits is 100%. That means the remaining women had 3 visits, all of them, 3 visits. But the index only tells us 49% have attained, 49% of population attained ANC 4+ coverage. And then you want to compare that with another country that has 49%, and that country is this, and your country is this. So these 2 countries are different in terms of coverage. Even though the outcome of measure is 49%, you think those 2 countries are the same. No, they are not the same. So if you look at this carefully, you will see that this is a possibility where 49% of pregnant women have attained at least 4 ANC visits, and then no one else attained any visits. 0. No other. There's no 3 visits, there's no 2 visits, there's no 1 visit. It's basically 0. And it's, of course, the coverage indicator is 49%. But if you compute the index I've given you earlier, there are different values. Okay? Can you see different values? But if you're using the 4+ index, it's the same value for these 4 scenarios will give you the same 49%. But clearly looking at this, we know that ANC coverage in panel A is better than the rest because it's about 87, it's not percent in this case, 0.87, it's an index. So we can't really say it's percent. But the worst is that one, is 0.49. And in between you have the 0.62 and 0.73, not 0.72. So these nuances are ignored when you look at the traditional having at least 4 ANC visits. You don't pick this up. So now let's generalize. Let's move back quickly to a generalized index that will be able to accommodate quality of care or content or whatever you want to call it. Now the problem is, I will state upfront, is it's difficult to measure quality, likely because it's multidimensional across different kind of specs. It's more, I'll talk about that as I move forward. So now let's imagine, this is another quick one. I'm not giving you the background to where this comes from, but this has a lot to do with the first equation that I didn't show you. But the whole idea is that you're computing an average. This is an average. And the average is an adjusted coverage. So the coverage is going to be adjusted, and adjusted for quality. Now, the way I have introduced quality in this model is to assume that you can scale quality from 0 to 100% or 0 to 1. You should find a way to scale quality, because it will be difficult to qualitatively, which is what it is, qualitatively put quality into this model. So you must find a way to kind of quantitatively scale quality from 0, maybe no doctor at all or something, to 1, with 0 being, 0 is actually not no quality, but 0 is no service rendered. Okay? That means there was a visit, but you went home without any service rendered. So basically it's 0 quality. There was a visit, but there was no visit, kind of stuff. Then you have 1, which is the best quality that you can imagine. So if you introduce that into which I didn't show you the equation for brief, I just cut it off. You would basically compute an average that is adjusted for quality of care. And the quality of care that I introduced here is for each visit. So I'm not saying the quality of care to a particular hospital, and that's the multidimensional level I'm talking about. That each visit, there should be a measure of quality. Because an interaction between the patient, well, not necessarily the patient in this case, because a pregnant woman, between the woman and the care provider. And that relationship, in terms of quality, has to be mutual. In the sense that the woman has to make herself available as well as the provider, and the context has to be right. There should be drugs, there should be basic equipment, etc. So we can also compute the quality gap in a similar way as 1 minus whatever you estimate here. Pretty much simple. So now let's look at how we apply that empirically. I first of all took the DHS data from Uganda to do an in-depth analysis, and thereafter I did a comparative analysis looking at 34 African countries. But this time around, I only did for the coverage and gap without the quality adjusted, because I'm still struggling to come up with measure of quality within the DHS, because that's what I have. I don't have anything other data to deal with. Okay, now let's quickly look at results from Uganda. In 2011, we see that about 49% of pregnant women have attained at least 4 ANC. That's reported the past five years. That's what is reported in the DHS. So about 49% of women have had at least 4 ANC visits. And that is basically high compared to the proportion that have attained 3 visits. This is 4 or more, this is 3 visits, this is 2 visits, this is 1 visit. And if you look at this cumulative, it tells us that about 3% of women, or about 4.3% of women have not had any ANC visit. 4.3% have not had any visits in Uganda to any formal health provider while they were pregnant. Just worrisome. If you look at the index that computed with the gap, though this shows up as 48.5, the index comes up to about 0.79 and then the gap is of course the difference 0.2221. If you look between urban and rural, it's usually the case. Coverage is higher in urban compared to rural, higher amongst people with at least secondary education compared to no formal education and of course primary education. And the reverse is the case, the gap will be higher because there's higher gap for no formal education compared to at least secondary education. In terms of quintiles, the gap is higher for the poorest quintile compared to the richest quintile. For policy, it's also important not just to look at the overall 0.789, but to also have more disaggregated coverage indicators to know exactly where to target. Because it's possible that this will be this, and you have 100% here, but the rest not. 100% coverage here, but less than 100 elsewhere. I don't know whether you can see this, but I try to make sure you see it because it will be difficult to split them. So this is a more detailed analysis looking at DHS data from 34 African countries to compute that index as well as a coverage gap. And I basically ranked countries based on the new index and then compared the rank with the previous using the traditional WHO index. So I would highlight the ones I want you to see for a while. Now there is some kind of correlation between these two rankings. Some kind of correlation there. And the correlation is higher at the tails. You could see 2-1, 2-1, 2-3. 2-1, 2-3. Now, remember, I showed you Sierra Leone. I said I'm going to come back to Sierra Leone. Sierra Leone had a very high maternal mortality rate. Very high, even very high neonatal mortality rate. And it comes out as Africa's best in terms of coverage rate for ENCVC, which is very positive. Very positive. It's like the direct reverse. The best in terms of ANC coverage, the worst in terms of maternal mortality in Africa. So it's something that really interests me. I'm really keen to dig deep into understanding why Sierra Leone is showing that kind of relationship. Apart from Sierra Leone, if you remember very well, we had Nigeria, Chad, and of course Ethiopia has become known in terms of high maternal mortality. This I could explain. Mali, Nigeria, Chad. But Sierra Leone, unexplained. And that's the case even if you use the 4+ ANC coverage. Pretty high. Second, of course, very high compared to Ghana. Ghana is one of Africa's best in terms of ANC coverage rates, using the new indicator as well as the old indicator. So you will see that some countries have similar ANC4 estimates, but there are variations in the ranking if you look at the new index. That's then that even though there is some kind of correlation, there is also difference. There are differences between the two rankings because in Senegal and Mozambique, for instance, you see Senegal has a very good new ranking, but previously it's not ranked well because you have a large proportion of Senegalese women who've attained at least 3 ANC visits. So there's kind of progressive realization in Senegal compared to another country that was ranked in the same maybe around 23 or thereabout compared to Madagascar, for instance. See, Madagascar became very bad, even though it was ranked pretty close to Senegal before. Again, Mozambique has that kind of improved a bit from 21. Oh, sorry, it wasn't ranked from 21 to 26. So ranking changed. You have countries with better ANC4 ranking, but poor new ranking, e.g. Nigeria and Guinea. Let's see, Nigeria and Guinea. Then, of course, you have countries with better new ranking, but poor ANC ranking, e.g. Rwanda. Rwanda is also another case that came up, and I was wondering why you have Rwanda is reported as a country with very good maternal mortality and maternal health indicators. But using the 4+ ANC visit, it's very, very low. But if you look at the new ranking, it puts it higher, which is reflective of what is reported in Rwanda compared to if you look at just the ANC 4+ visits. So using the ANC 4+ alone to assess progress in ANC coverage will miss critical improvements in terms of how countries try to increase the proportion of women who've attained less than 4 ANC visits, any kind of progressive realization. Because women with fewer ANC visits, like shown, come from poorer socioeconomic backgrounds. And that's exactly what you want to target, to increase the proportion of women in poorer socioeconomic backgrounds that have attained at least 2, 3, 4. You want to move it gradually rather than kind of move. Then using the new I index provides an avenue to assess progressive realization of access to maternal health services, at least in this case, using ANC visit as a proxy. In the paper, I also generalized issues around going to measure quality of education quality as well. So it's beyond just health, but also it can be used to assess quality of education coverage and education coverage gap, especially for kids. And we also address issues around timing of visits, etc., which can be adjusted. The indicator can be adjusted to account for timing of visits via the quality. See, that's where the quality is fine. In the sense that it's not just all about the service being rendered, but also how the mother is, or the pregnant woman makes herself available for services. You can have the best doctor giving you the best treatment, but if you appear late, there's nothing the doctor can do, kind of stuff. So, and then you might record that the quality is low because the outcome was poor. And that is driven not necessarily by the provider, but by late appearance of the patient. So, a whole lot of debates around the multidimensionality of quality. Either whether quality can be assessed from the patient's perspective or the provider's perspective or from a kind of system-wide perspective. Yeah, that's another kind of work. I'm engaged with a group at Harvard looking at quality of health systems, broadly defined, not just looking at quality of services. Then the more generalized indicator accounts for quality of ANC received by pregnant women. Like I said, you can scale that quality any way you want it to go. However, there are issues around how to measure quality, which I'm unable to go into debates. So as the first step, we're suggesting ways to include quality indicators in routine data collection processes, so that we'll be able to assess as much as possible multidimensional nature of quality. And a related aspect that is very important to keep in mind is the delivery by trained birth attendant, which can be, of course, predicted to some extent by having a high indicator estimate for this. Now, the reason is because if you had very good contacts with a provider before birth, you have a higher probability of being attended to by a trained birth attendant than if you've never had any prior contact. So that's the reason why this is possible, that you have a higher quality adjusted indicator of coverage, predicts to a very high extent the possibility of being attended to by trained professional, because trained professional will tell you when to come up and how to deal with the pregnancy. So women receiving high quality ANC will be more likely to use a trained birth attendant compared to women who did not receive ANC visits at all. So, thank you. Yes. Next question there, yeah. Yes.
Oh, okay. Thank you very much. Very educative presentation. But I'm very concerned as a nurse midwife because what you're presenting lacks the midwifery voice. Because as somebody who works with pregnant women, the 4 visits came up because the 8 we used to have 8 before we implemented what we call focused antenatal visits, which are just 4 visits. And all of them are assessed qualitatively, in the sense that each visit has its own purpose. Somebody doesn't just go to the clinic and come without a purpose for that visit. So my concern is just you not involving people that are doing the actual work. I'm sure if you really had involved a midwife, even one midwife would have gotten the essence why we are having 4 visits and the quality that is involved with that. For instance, I'm Zambian, and if you get to even the remotest rural clinic in Zambia, there will be a midwife there. There won't be a doctor. There will be a midwife there. And they are the ones that offer the antenatal visits that we're talking about. And each visit has its own objective. If a person comes today, there are things like for first antenatal booking, you know what you're supposed to do on the first antenatal booking. So it's just that voice is missing, and it looks like there's nothing that has been done, and there's nothing that midwives do out there. But we really have the quality aspect measured in that, because if we say this person came for first antenatal booking on such and such a day, and we didn't do PMTCT, we didn't do, like for instance, we didn't give, if somebody was above 8 weeks, we didn't give FANSTA, which is given for malaria prevention and all of those things. So we have all of those standards. It's just the issue of involving people that are doing the actual service when you are trying to come up with those things. It really sounded like you were just focusing on your study.
Yeah, let me quickly talk to that. Just keep in mind that what I've done is to use an existing survey. I am very much aware of what you're saying, very 101% aware of the different packages that women are given depending on which visit it is. But the challenge is not knowing that these things exist, but the survey I have, how does it capture that which you have mentioned? The surveys that we have with the DHS only measures the number of visits that you had before you get to birth of the baby. And that ends there. And that's the reason why I say it's important now to begin to bring in those quality measures you mentioned, as many. And the quality measure, like remember I said, has to do with each visit. I didn't say hospital. I said each visit. So if a visit you have XYZ, it has to be assessed and the quality measure given to you. So each visit is different, it's unique. That's why I kept emphasizing that it's not just about quality of the hospital, which you can easily get. They say, well, comparative analysis of hospitals, this has high quality. No. Each visit has to be assessed by quality because it's a match between the mother or prospective mother and the provider, which could be a midwife, a nurse, a doctor, whoever the provider is. As a matter of fact, there's a study done in Zambia, which I read. Yeah, correct. Yeah, great. About exactly what you're saying. Looking at quality, trying to assess coverage, but looking at quality. But in that study, what they did was to look at the content, content of each visit. So they came up with a measure to say, well, the first visit you have XYZ, second visit you have third visit if it's within the X trimester you have kind of stuff. And they assessed whether if the kind of intervention should be 12. If you received 12 of the intervention, then quality is 1. Or if you received 8, it's 8 over 12 kind of stuff. Quality. Again, it's crude, but it's a way to get closer to the real thing. Because it's possible that they are not equally weighted. Okay? The 8 or the 12 interventions may not be equally weighted. One intervention may be very important, and if that's missing, and you have 11, and the most important one is missed, you can't really say you have a very high quality. You know what I mean? So there are a whole lot of issues around that, which I don't want to go into. But I take your point in terms of getting to involve midwives, not just midwives, but providers across the spectrum. Yeah, I think that's. Let's be first.
So I wonder if you also weighting each visit equally in the way you're doing that analysis. I wonder if there's any evidence that you should weight the first visit more than the next visit and the second visit more than the third, that sort of thing. And you've got the data so you can look at whether it relates to outcomes. And you also never gave us the punchline about Sierra Leone.
About
Sierra
Sierra
Leone.
Leone. Oh yeah, okay, right. Yeah. Good.
We're waiting.
Yeah, good. Now, in terms of weighting or literature around whether the first visit is more important than the second, the third, the fourth, blah blah blah. If one answer I'll give is yes, there may be differences in terms of the importance, but the differences will not matter much if I'm computing averages. I'll tell you why. Now, the reason is, or what matters most is the quality of that visit rather than whether that visit should weigh more. Because if you've had two countries with the same number of visits, first visit, irrespective of the weight I give to the first visit, it cancels out, it still gives me back the same. For instance, if these are all countries, this has 10%, 5%, 8%, 6%, and then I decide to weight that first visit by 80. If I weight the first visit by 80, I compute the average, it's basically shifting the mean. So it shifts the mean, but it's relatively you're all the same because I've assumed that all first visits should be weighted equally. So everyone with first visit will always have the same weight. The only difference will now be where it will be relevant is when there is light difference between the proportion of the first, the second, the third, and then you're aggregating. Then of course you miss the kind of relative weighting. Yeah, good. But now, kind of, interesting, but kind of complex. Complex in the sense that the measure, it's. I can explore that to see whether you have, What matters to me most is the timing of a visit. It's for me very important than trying to see whether the first visit is more important than the third and the fourth. For the timing, if the first visit is the third trimester, it's problematic. Well, my own saying. But whether now, if you now say that's the first visit in the first trimester and give it a very high weight and it's wrong, it's kind of wacky. Yeah. So I don't know, but I'll think about it. You know what I mean? Like for instance, you get the first visit, and the first visit is in the 8th month, and then you say, well, this is an important visit, give a very high weight. But in actual fact, that visit is wrong. It's the wrong timing. It's not right. So you are now giving a very high weight, which is good, but yeah, I don't know. Yeah, I think about it. Then Sierra Leone. Now, the moment I saw Sierra Leone coming up, that's even more, very recently, that I saw this inverse relationship. A few weeks ago, actually, because I'm still working on this. Then I now saw Sierra Leone coming up. I said, okay, well, let me dig deep to see why Sierra Leone has a very high maternal mortality rate, but it's coming out very good, tops in terms of ANC coverage. And while I've not been able to really find out what the heck is wrong with Sierra Leone, one of my first feelings is to see perhaps there is a gap between timing, which is something I can't get automatically, maybe the timing of visits, or the quality of services rendered in Sierra Leone may not be adequate, which we may be able to capture if we compute the quality indicator, which I have not computed. So it's still speculative, but I'll try as much as possible to contact a few guys in Sierra Leone, back home. This is my region. So I'll be able to get a few guys in Sierra Leone to know why we have very high maternal mortality and if they have any reason. But I will dig deep to see whether I can come up with Richard first. Yeah.
Richard, there's the same question as Daisy.
Okay, then.
So I think two things from me. I think the Sierra Leone example is a very good case for why one then has to supplement these really, really useful quantitative works with qualitative explorations and trying to get to the bottom of what's going on. But the second thing is, I think when you presented the issue of coverage versus gap, we had a very interesting discussion in the Journal Club yesterday about how when one talks about performance and so forth and so on, we tend towards the negative kind of language, so gap, lack of, insufficient, and so on. So I think what your model presents is an opportunity to talk more positively about what one has achieved, because it does something for the psyche of a country or groups of providers or citizenry, especially if one has to account back to the citizenry. Not that you want to hide the fact that there are, in fact, gaps or inadequacies and so on, but it allows one to talk about achievements such as a high proportion of 3 visits, for example, in a more positive way. Because I think we're so dragged down by the negative and what our deficiencies and what our gaps and challenges are, that it's actually good to start to generate data that allows one to talk in a more positive language about what has been achieved, sometimes in very difficult situations. So I appreciate that. Yeah.
Thanks. Yeah.
Thanks very much for a really interesting presentation. I really like the mathematical notation. It was quite helpful to remember stuff that one was taught many years ago. I'm curious about your source of data, because it sounds like you've got access to data. Where did it come from on an individualized basis like that? You've got measures of quality, and you've got measures of numbers of antenatal visits. Yeah, where did you get that from?
The DHS, although, like I said, the quality indicators in the DHS are not that great. Not that great. Some DHS, I mean, it's not that great at all. Not great. But what I have access to is the number of visits that you've had, whether you've had 1, 2, 3, 4, 5, 6 visits. It's there in the DHS. And DHS is freely available if you want. If you want me to send to you, I'm happy to. You have tons of them. Send them to you. Yeah. Does that really answer?
Yes, but are you able to get the data to the individual level?
Yes. To the mothers, each mother. Of course, I can pick the number of children you have. I can pick the number of visits you have, and I also know your educational status, your blah blah blah. Of course, yeah, it's individual level and household level. You can compute household indicators, like whether the household has XYZ, a car has a blah blah blah, and you can also tell whether the mother has a primary education, the mother has well, the occupation is not so great, but whether the mother is in the rural area, the urban area, then that's right.
Yeah, thank you for the presentation. I have to disclose first, I have a medical background, and which means I have I know the issue about the quality. The quality is still critical, and that's why I want to raise the issue on this index and which type of the data. And I think if you have the qualitative data, this would be maybe more comprehensive to have a clear picture on the robustness of the index, and especially when you mentioned the Sierra Leone, where I work in that country, I was surprised to see this ranking, and even myself, I experienced the death of the women during the delivery, and they tell you that she has. I remember one nurse was saying, this had made already the 5 visits, but what is happening? So which means the quality is still critical. So it's not about whether you have done 10 or 20 visits. So quality indicators, I mean the overall will be critical. I know there are some tools where you can have the overall countrywide, they call it the healthcare assessment tools. I don't know, maybe
Sarah,
exactly. Maybe they can help you find the more comprehensive information about the qualitative data to inform this index. Maybe this will be much more robust in terms of having the idea of overall the country of this indicator. Timing is very important. And where to find this information, it's not clear. The data source we have, I have worked in one of the performance-based financing, where at least they try to make sure that the timing is really reported in when they paid off incentive after the evaluation. But still, as you are saying, Sierra Leone have had the PBF over 65 years. And they get incentive because of the quality of the score is very high. How is it implemented? That's the problem. And even the data, sometimes they can inflate, or they can doctor data because they want to get more rewards. So the basic would be to look into the data and the quality of the data you are getting, and especially the quality side. Yeah, that's.
Yeah, you raised a very important quality of data. Yeah.
Thanks, John. It was very interesting. I mean, from a point of view of access, I think it's really nice that you're looking at progressive realization, because access is often so narrowly defined, just one point or one point in time or one number. So, I mean, I think that's absolutely fantastic. And what has been the response to your work? Has anyone, you've published, you've presented elsewhere, what would be?
This is the first presentation I've ever had of work. So, yeah, it's work in progress. It's the first presentation I've ever had. So, yeah, never had any. Yeah.
I think that's great, because it really does provide more insight into distribution of services, and you'll be able to look at equity in a different way, perhaps. It provides so many interesting research questions that could last for another 100 years. Yeah.
Thank you. I actually submitted it to a Canadian conference, Canadian something public health conference. If it gets accepted, then possibly
Hi, thank you for the presentation. Do you think your methodology is applicable if you have data that you're collecting routinely, let's say provincial level, and you want to compare district level of coverage?
If you have that data, because I'm looking for nuanced data to be able to really, I'll be happy. If you have the data, then come chat me. I'll be happy about it. If you have. Yeah, because this is kind of macro. It's what I have. I don't have data. But I'm only trying to propose an index. And if I have nuanced data, I can really crunch something important.
Triangulate.
And triangulate and stuff like that. Yeah.
Can I just add to that?
Yes.
So, John, that's really interesting, because if you do it at a district level and you're working with a group of people in country, you can actually raise questions to them, say, yes, well, I can't tell you exactly what the quality concerns are, but you now at least have a research question to engage your health managers, as to say, look, guys, the outcomes are bad, but it looks like you have your coverage. So I think at a national or provincial level, this kind of work is really useful for raising questions about quality. You may not answer it, but it's raising it.
Yeah, I agree totally. Because what that will assist me doing is to add a third row, column, which I never had. It's about the quality adjusted. And you see the ranking might be weird. I'm telling you, the ranking might be weird. I might pick up Sarah as being back. Thanks, guys. It's been a nice one. I appreciate your coming, even though it's kind of holiday.
Yeah, you got a bad patch of the year.
Yeah, thanks.